Dr. William House, an otologist, and I'm here with Dr. William Hitselberger, my esteemed colleague and a neurosurgeon. We are here to kind of introduce and talk about some of the very early days of microsurgery and the introduction of microsurgery to various intracranial procedures. Sort of my introduction to microsurgery actually came at the very end of my residency in ear, nose, and throat at the Los Angeles County Hospital. Up to that time, and I finished my residency in 1956, there really wasn't any microsurgery being done in the United States. Microsurgery was introduced in Germany for various procedures on the temporal bone, primarily a new procedure which at that time was called tympanoplasty, still is, but it was an attempt to improve temporal bone surgery and try to restore hearing to patients who had chronic infections and were previously only operated on with radical surgery, radical mastoid surgery. I first saw the microscope when Dr. Woolstein, who had introduced this in Germany, demonstrated some of his work and some films that he had made through the microscope. And to me, it was a whole new revelation because the microscope allowed me to see for the first time many of the intricate structures of the temporal bone, which previously I could see with a headlight and a loop, but they just were not in the clear, vivid anatomy that you could see through the operating microscope. Now, there had been attempts to introduce microsurgery into otology for some years, but the microscopes were not really suitable for surgical procedures because if you went from one focus to another, you had to change the focal length and change position of the microscope. You also had to lock it all down because they were not balanced in any way. And so it was very inconvenient to even try to use a microscope, and there was only occasional use for it and very limited applications of certain types of ear surgery. In Germany, however, a very important development by the Zeiss company was that they developed a microscope that had the capability of remaining in focus even though you changed the power of the microscope. And in this way, the magnification could be changed even without moving the scope, which was a really great advance. The other advance, of course, was that they devised the lighting so that the light was coaxial with the view of the surgeon, and the microscope was truly a binocular instrument in that there were two complete ocular chains, I guess is the word, that gave you true binocular 3D vision. So with this marvelous instrument, a whole new field of microsurgery began to open up. I was fortunate in that I had some background in dentistry. In fact, I am a dentist, and I spent 2 years in the Navy as a dentist, and therefore I was very familiar with the use of diamond stones and irrigation to work on various types of procedures in the teeth. So after I'd finished medical school and now finished my residency, I had the background of utilizing this type of technology in fine temporal bone surgery. And so we developed then better methods of irrigation and suction, whereas before we used to have to squirt the wound and suck it out and then drill a little bit and then squirt and suck, and it took forever to do temporal bone surgery that way. So we developed methods of using continuous irrigation and controlling the amount of the suction by rotating the thumb on a thumb opening at the suction. This was then made it possible for us using diamond stones, continuous irrigation and suction, and the microscope to really develop the whole field of microsurgery for temporal bone surgery. About this time, I also became very interested in the possibility of attempting to restore hearing in patients who had hearing loss from otosclerosis. We were began doing a lot of surgery on the stapes, but there was a lot in the literature at that time that maybe the problems with otosclerosis were really due to pressures of the bony lesions around the internal auditory canal. And so the reasoning was that if we could possibly decompress the internal auditory canal without damaging the facial nerve or the hearing, that maybe we could restore some hearing to those patients who had progressive hearing loss of a sensory neural type from otosclerosis. So I began working on the possibility of approaching the temporal bone from above, in other words, through the middle fossa. And this is why I began working that time with a colleague who had been a resident at the same time I was, Dr. Ted Kersey, and I introduced him to the possibility of utilizing the structures of the temporal bone from a superior approach by following along the greater superficial petrosal nerve to the geniculate ganglion and then letting that lead you down along the labyrinthine part of the facial to the internal auditory canal. And we did several patients who were totally deaf in an attempt to decompress the internal auditory canal from above. Unfortunately, none of those patients had any restoration of hearing, but we did develop what obviously was a very useful procedure for dividing the vestibular nerves, for dizziness, for decompression of the facial nerve, and of course, I became very interested in the possibilities of maybe extending this kind of surgery to the use of removing large acoustic tumors or any acoustic tumor. At that time, we could only diagnose them when they were very large because all we had were air studies. And so later on, Dr. Kersey and I, unfortunately, were not compatible in terms of working together, and so for a number of reasons, we kind of had our fallings out. But I began working then with Dr. Jack Doyle, and we did several acoustic tumors in an attempt to save the facial nerve. Now, there was very little being done at that time on trying to save the facial nerve in acoustic tumor surgery. So the microscope was first then introduced to intracranial surgery for the reason that we wanted to decompress the internal auditory canal, and then it began to expand into the possibilities of utilizing the microscope for removal of tumors in an attempt to save the facial nerve, because for the first time we could really see the facial nerve. And there was a lot of controversy about the use of the microscope, because I know the feeling of both Jack and of Ted was when we got into any kind of bleeding, if the scope was in there, you'd have to get rid of that in order to see the bleeding and get it controlled. And I kept saying, hey, wait, it's going to be the opposite way, because now you can actually see where it's coming from. You got a chance at doing something about it. So we began working with the microscope and doing some tumors where we had the patient seated and we were drilling off the whole top of the temporal bone, skeletonizing the facial and attempting to remove the tumor that way. First 20 cases that I did with Jack Doyle were done with that procedure, and then gradually it became apparent to me that if we could go through the temporal bone, primarily through the mastoid, through what we now call a translabyrinthine approach, that would be much easier in terms of the anatomy that I already knew from temporal bone surgery. So fortunately, about 1963, a young fellow came along, Bill Hitselberger, not so young anymore, Bill, and Bill began working with me, and so we'd like to reminisce about how things developed once we had in place the use of the microscope, the use of irrigation suction, the concepts of temporal bone surgery combined with intracranial surgery. And over these 28 years now?
Yeah, 27.
28 years, Bill and I have worked daily together, very closely, fortunately very compatibly. I have a great deal of respect for Bill, and I know he does for me, and so it's been a wonderful relationship, and it's been a chance to develop posterior fossa surgery, and particularly CP angle surgery. And Bill, you might sort of reminisce a little bit about the early days when we began working together, and I was teaching you about temporal bones and you were teaching me about neurosurgery, and so we had some great sessions.
Yeah. When I first started working with Bill, I had pretty much the same preconceptions of the microscope, I guess, that Dr. Kersey and Dr. Doyle did. This was totally unknown at that time. I hadn't any experience with this as a resident. And I remember when I was first working with the microscope, I felt very uncomfortable at first. But as Bill said, I got into bleeding once on a case that he wasn't on, and I'll remember this very well. And my inclination was to get the microscope out of there. There's blood all over the place, but I didn't do that. And I kept the scope in the field, and just like he was saying, I could see where it was bleeding from a lot better than if I had put a suction in there. And at that point, I knew that I was a microsurgeon and that was going to be an integral part of what I would do for the rest of my life. And I think that's very important. The other thing that was interesting as I listened to Bill, what you were doing at first was really, with Jack Doyle, was a trans-lab approach from above.
Right.
And I remember I don't know if it was a case or a series of cases, it was written up in the LA County, remember that Journal of Neurology and Neurosurgery, whatever it was. But Jack and you, I don't know if you were a co-author on that or not, but Jack apparently felt, in that article anyway, that that whole posterior fossa had been opened up by doing that. And it, as you can see, you can still do that, but it's a lot better and a lot faster if you use go through the mastoid and do it that way. Are you acquainted with that particular case?
Yeah, I remember, and that was one of the things where Jack and I had some disagreements, because actually, to me, having the patient seated with their head in the tongs and so on, where it took us sometimes a couple of hours before we were actually even ready to do the incision. And yet, to me, it was so much nicer to have the patient prone with the head turned to the side. And Jack just felt that this was really not the way to go. And so, fortunately, that's about the time you came along, and you and I developed a very, very good working relationship. And you were willing then to get in the temporal bone lab and learn how to do temporal bone surgery. I tried to teach Bill as much as I could, and he was a very good student, learned how to drill out the temporal bone. And so we had a lot of...
May I interject? I have to tell this one case where Bill is absolutely right. He taught me everything I knew about the temporal bone and the microscope, for that matter. But there was this one case that kind of cemented our relationship, and it might have broken it up. But I had done the bone exposure, and I was drilling out the what's called the labyrinthine part of the nerve, and I went right through it with the drill, and I didn't recognize it. And Bill came into the room, and he's usually a lot more calm than I am, and he was really mad. And he said, "Look, if you don't drill out," do you remember this case?
Yeah, I do.
He said, "If you don't drill out 10 temporal bones and show me that facial nerve, I'm not going to work with you anymore." And, you know, I'm the big-time neurosurgeon and all this nonsense. But at that point in time, I really was getting into it. And so I did it. And Bill looked at every one of those. And so I finally learned by doing that how to dissect the facial nerve. But the interesting thing on that case was that was the first time that we had ever done a direct anastomosis of the facial nerve. I'd gone through it, but I knew that if I could hook those ends of it up, that we would get a good result. I don't know if you knew that or not, but in any event, it worked out real well, and the patient had an excellent result. But I think that there was another case that that comes to mind early on. This was a neurosurgeon who was one of Dr. McCarty's residents, Dr. McKinnon. And he was from up in Sacramento someplace, or somewhere
Fresno,
up there,
yeah.
in Fresno. And in any event, he was referred to Bill. And so he had a big tumor, and he had the option, of course, of going wherever he wanted. And at that point in time, the mortality of acoustic tumor surgery in California was 40%, operative mortality. And so Dr. McKinnon, and he's still alive, by the way, doing very well, but he, of course, was very scared, and one thing and another, as probably we all would be, but he let Bill and I do them. And we got the tumor out, and that evening he started to bleed. And I remember his associate said, well, I want Dr. I was just out of my residency then, and I wasn't, I guess, that well known or whatever. But in any event, his associate said I wanted Dr. such and such to take care of him, and I didn't want Dr. Hitselberger to take care of my associate. So, I more or less told this to my associate, and he said, I don't want to have any part of it. So we were there, and we had to do it ourselves, and we stayed up with Hector the whole night. He would get obtunded, and we would suction out some clot, and he'd be all right, and then he'd go back in, and finally we pulled him through that. But I think at that point, Bill realized that, we just had to, if this was going to go anyplace, we really had to each teach one another as much as possible about what the other knew. And I think from that point on, we really developed this team-type approach to this, which is one of the great things that I think Bill has done. I would do a lot of the mastoid work and the temporal bone work, and Bill would do a lot of the tumor. And we worked more or less interchangeably. And I think that even now, anyone that's had any training with us, that's one of the things that we stress.
Yeah, I think as we went along, we were sort of learning a lot about how to avoid a lot of the morbidity and even mortality that we had at that time. One of the things that I remember we used to have a lot of problems with was when we were taking out the tumor and developing the capsule. Remember, we used to put a whole bunch of cottonoids around it, and the patients would develop brainstem signs because we were compressing the branches of the ICA, and finally it sort of tumbled to the fact that we were often losing the planes by doing that. And as we cut down the amount of cottonoids that we were using and increased the amount of irrigation, I think a lot of our surgical time improved. And we went through a lot of different developmental stages in the development of our approaches to these acoustic tumors. And Bill, maybe you could talk a little bit about our concepts of decompression of the posterior fossa.
Oh,
Remember
yeah.
that?
Well, I brought a lot of ideas that I had learned as a resident to our approaches to acoustic tumor. And unfortunately, a lot of those concepts were not any good, and they were in fact dangerous. Bill went along with this because I don't think, Bill knew a lot about intracranial stuff, and he went along with it. It seemed reasonable. One of the things which was horrible was the concept of ventricular decompression with a tap and tapping the ventricle in large tumors. Now, at that point in time, the great majority of our cases were indeed large tumors. And I would tap the ventricle, get away with it sometime for decompressive purposes. But sometimes I wouldn't get away with it. And what was happening was an upward herniation of the brainstem through the incisorial notch, and I'm sure occluding the major vessels to the brain. And this was not a good thing to do. We had it. Remember that young guy that I remember this case very well, where I tapped the ventricle. It was early on in the case, and at that point in time, we didn't have ventilators. The poor anesthesiologist would hand ventilate these cases because we were monitoring very closely the respirations and the blood pressure. Most of the time, not always, but in general, when the anesthesiologist said, you know, he's just not breathing well anymore, he's not tripping the respirator, this or that, that was an ominous sign. And I'll never forget tapping the ventricle in this particular case, and that's exactly what the anesthesiologist said, and we lost the case, lost the patient. That was obviously not a good thing to do. And then the other concept we had was this business of posterior fossa decompression. You had to decompress the rim of the foramen magnum. And so for probably 50 cases or so that we did, I would, as a preliminary procedure, maybe a week or so ahead of time, I would do a wide suboccipital decompression, taking off the rim of C1 and C2 to decompress the posterior fossa. And this, again, was totally unnecessary. And it was apparent that we could do the same thing by two maneuvers. First of all, by rapid decompression of the core of the tumor, and secondly, by decompression of the cisterna lateralis, which we could do. That would accomplish the same thing and obviate the necessity for doing that other procedure.
So I think sort of what Bill's saying is it took us a long time to kind of realize that rather than trying to decompress by removing spinal fluid from lateral ventricle or decompressing by taking bone off the back and so on, the best way to decompress was to open right over the tumor through the translabyrinthine approach and take out the center of the tumor, and then the tumor was allowed, or the pressure was allowed to decompress as it should through the tumor itself.
Right.
And that was a whole new sort of concept that I think took us a long time to kind of develop, but once it was developed, it certainly improved our morbidity and mortality a lot. And this is something that I think was really not, and maybe not even today, completely appreciated as much as it should in regards to cerebellopontine angle surgery. If you can approach that angle right along the internal auditory canal and over the posterior fossa dura, right over the cerebellum, then you have a much better chance of handling the tumor without the brain herniating either upward or downward or whatever. And that, I think, cut down our morbidity and mortality quite a lot. I think other interesting things that we gradually began to realize would be that one of the things that the microscope allowed us to do was to actually see very clearly all the vessels around the tumor. And as we were developing the planes of the tumor, to be able to come to those vessels and then dissect them off directly off the tumor itself. And the problems of, in the surgical cases that I worked with other neurosurgeons on in the very early days, where we were sometimes doing suboccipital approaches, those vessels would often be with a poor headlight type of approach and the loops or whatever was being used. They just weren't seen very well,
Right.
and we couldn't handle it well, and so there was a lot higher incidence of the anterior inferior cerebellar artery thrombosis, or even those vessels were actually clipped or
Of course, you were using the monopolar coagulation at that point in time.
right.
And remember, I think Bill was the first one that I knew of anyway that ever figured out that what was happening with the monopolar coagulation, there was the current was being transferred down the conduit of these arteries.
Right.
The worst thing you could do. And that was initiating this thrombotic process, which was resulting in major complications to our patients. So Bill devised bipole coagulation. And I think we probably were the first ones to routinely do that just because of this problem.
There was, I can't think of his name now, there was somebody down in Texas who had also worked on that quite a while and was actually, had published that you could do bipolar directly on the brainstem, which at that time was thought to be completely impossible.
Is that right?
Yeah.
Yeah.
I don't remember now who that was, but bipolar had just come in some instances, and I think it was a major advance.
Oh, yeah.
There are a lot of other little things that came along. For example, one of the things that we had a problem with, of course, is if the patient had a lot of problem with sore throat, coughing, and so on after surgery, that often would make it difficult because when they coughed, there was a lot more chance of developing cerebrospinal fluid leak, which was one of the things that was a major concern in the early days of that surgery, was that we wouldn't be able to handle these leaks very well. And so one of the things that occurred to us was, well, you know, all we'd have to do maybe is have a sterile endotracheal tube instead of the ones that came out of the anesthetist box. They used to carry those things that looked like a, remember, fish box, and they'd throw these endotracheal tubes in, and sometimes
incredible.
They'd wash them off with a
Yeah,
little
I
soap or
couldn't.
something, and that was it. And so the patients all had sore throats,
Sure.
and they'd cough, and so we began insisting that they use sterile tubes and throw them away afterwards, and this was just something that our anesthetist really didn't want to do.
yeah.
Those tubes somehow were worth $5, and that was
Yeah.
a big deal. You couldn't...
That was a big battle.
Yeah, it was.
Yeah. The other thing, of course, that Bill did, and I accepted this rather reluctantly at first, but now it's obvious that it's a supine position with the patient lying flat on his back, head turned away, shoulder on the level with the operating table, and a tube extending down over the torso. There's a major problems with the anesthesiologist, but this didn't impair anything in terms of the ventilation of the patient. And in terms of the safety of the patient, it was far better than the sitting position, with all the horrible complications that you see with that, and even the prone position. It allowed us to get the patient intubated, get him on the table, get him prepped, you know, within a matter of 15, 20 minutes, and that I think was really a major advance. I don't think. Well, you appreciated that because you had been exposed to this sitting position, Bill, and I think that was, you know, a really major thing in terms of neurosurgery in that area and in that era, because you know, the conventional, I'm sure Ted and Jack all wanted to use
No, they
it.
insisted on having
Yeah.
the patient sitting up, and it was very awkward to operate. In fact, we had a special stool built, remember, that had
Yeah, I
cameras
remember,
on
right.
it,
Yeah.
so that we could have the patient sitting and then drill off the whole top of the temporal bone, clear down to the jugular bulb, and isolate and skeletonize the facial nerve. It was a major procedure that way, and the other way it was really very much simpler. And I think that concept of being able to put the patient flat on the table with the head turned to the side And when you then drain the cisterna lateralis, you can let both cerebellums kind of fall away.
Oh, yeah,
And
sure.
it works so much better.
I can't believe that even now, I mean, there's still that much resistance to doing that. It's just mind-boggling. I think now, finally, neurosurgeons you have this park bench position, which I don't understand that, because I think, especially on a patient with a right-handed tumor, if you're a right-handed surgeon, you've got the shoulder in your way, and you get the same exposure in the angle by just turning the head away. And to put the patient on his side, it's still better than being sitting, but I think you'd get the same thing if you just turn the head the way we do. But that was, I think, a major advance. The other thing that Bill did was this concept of a team approach to this particular lesion. And by a team approach, I mean an internist that was intimately involved with the care of the patients preoperatively, that worked the patient up for us, that followed the patient from the first few hours after surgery, that made rounds with us, an anesthesiologist that knew what our problems were, and a radiologist. Early on, we were very fortunate in having Bob Scanlon, who really developed the techniques of panopaque study of the posterior fossa. And again, there were major problems with accepting that. But that was far better, far safer than, and far more accurate, primarily, than the pneumoencephalogram. And Bob really worked that out and worked with us very well in the management of these patients. And that concept, I think, still persists in the way we approach these things. And all the fellows that train with us are appreciative of the different modalities that you really have to bring to bear on this particular lesion if you want to have good results.
Yeah, I'd like to say a few more words about Bob Scanlon, because up to Bob's work in cooperating with us on the diagnostic radiologic procedures, we used to use the air study. And sometimes you'd get some idea about a little widening of the cerebellopontine angle on that side. Maybe you'd see a suggestion of the anterior aspect of the tumor, and that was it. And it was always considered to be a very dangerous thing, because if there was herniation of the cerebellar tonsils, then the concept was you had to have surgery all ready to go. You were going to go upstairs immediately and decompress this patient. You had to be ready to put in a burr hole and all that sort of thing. And all of that, Bob Scanlon, who did his training at Mayo Clinic, and apparently went back and they were trying to, I've forgotten what the reason was, but they had put some panopaque in the cerebellopontine angle on a patient. He brought these films back, and I could see very clearly that the panopaque had run out into the internal auditory canal. There was a little extension there that you could see. And I was very excited about this, and Bob, when we got to talking about it, we thought, well, gee, maybe that's something we should do. So we did begin introducing large volume panopakes. At first, it was
20 cc
of panopake.
Yeah.
And there was a lot of objection to this.
Oh, yeah.
I remember that we had a meeting one time where we were demonstrating our surgical procedures on the old black and white television, and it was a meeting with neurosurgeons and otologists. And I remember several neurosurgeons at the meeting saying they were very aghast that we were putting panopaque into the posterior fossa, that you would never know what was going to happen with any type of lesion that might be occurring from the fibrosis and so on. And I guess there were reported cases of that at that time. But my feeling was I'd seen so many head films of patients who had had back studies with panopaque, and as soon as they bent over to tie their shoes, that stuff was all over their head.
Exactly.
And I couldn't understand what the big controversy was, because panopaque in all over the whole subarachnoid space was very common
It was
after
absurd.
that.
That was absurd, Bill. There's
And-
no, I don't know the rationale for that, and surprisingly, that mindset was when we were in Sweden at that symposium. The Swedes were very much against that,
I know.
and I could never understand that. But really, the Panopake study, I think, and the early improvements in audiology made the acoustic tumor surgery, it started the whole ball rolling in terms of what we have today. I think you ought to mention how there, you know, when we first started this, how you were confronted with the advances that had been made in your audiologic perception of these tumors, and then the idea of the surgery itself at that point in time was lagging way behind. And that's kind of what I always think it's very touching, that story you tell about the patient that I forget who it was, but
Well, this was when I'd first started practice, and of course there was a lot of talk in the literature that I had read as a resident about how if you can discover the tumors when they're smaller, that you get much better results in removing them. And so when I was in practice, I was very interested in temporal bone X-ray because I had worked with Gilbert Roy Owen, who was a pioneer in temporal bone X-ray. And he had insisted that any patient with unilateral hearing loss should get a set of temporal bone X-rays, which was really at that time somewhat outside the usual practice. So I was getting these films on these patients and discovered within the first year of practice 2 or 3 acoustic tumors. One of them
just on the basis of the temporal bone
on the
X-ray?
basis of the widening of the internal auditory canal and
Yeah.
unilateral hearing loss. And I sent this one patient to the neurosurgeon I was working with at the time, and he said, well, you know, here's a patient now with a little hearing loss, a little bit of tinnitus, getting along fine. I agree, he probably has a tumor, but if we operate on him, there's a certainty he'll have a facial paralysis. There's a good chance he may end up with cerebellar ataxia. There's a high mortality with this. So let's just wait. And so we waited, and unfortunately it was one of those cases where the tumor, obviously now we understand, was kind that started out in the cerebellopontine angle. Those are the kind that get very large before they cause very many symptoms. So within a matter of a year, he had papilledema. And so went in suboccipital. I remember I went over and watched the surgery because I was very interested in it. And the patient, obviously on the table, had a thrombosis of the anterior inferior cerebellar artery. I think it was torn and had to be clipped. Patient never woke up. And in discussing the case later with a neurosurgeon, he said, well, of course, you have to understand that he did have a big tumor. And I'm thinking, well, you know, why didn't we then accept some of these problems? And it became very apparent to me at that time, and since I was working with a microscope and so on, that the whole secret to this was to be able to somehow save the facial nerve. Because if you could do that, then there was a possibility of operating on smaller tumors. But if we couldn't save the facial, then very few surgeons were going to accept all of the complications that were occurring. And so very few patients were even operated until they had either papilledema or extensive fifth nerve findings. And so the mortality and morbidity were very high, as you say, 40%, just because of the way we were handling the situation then. So that was, to me, the key. And when we began developing these middle fossa approaches, where we could see the facial, know where it was, try to separate off the tumor and so on, that, to me, was the important thing about being able to cut our morbidity and mortality by developing procedures for smaller and smaller tumors. And the facial nerve, I think, was the key to that. Now, in the literature, of course, it was Dandy that was the first one to really always get the facial nerve doing tumors, because Cushing rarely removed a tumor totally. Dandy was the first surgeon to publish a cure of an acoustic tumor. And he did that by taking out all the contents of the internal auditory canal. He would put a cautery up into the internal auditory canal to kill all the rest of the tumor in that area. And of course, there was no consideration about trying to save the facial. And he publicized, and rightfully so, that the loss of the facial was a worthwhile price to pay for the cure of an acoustic tumor. But it was also a very high price. And the whole concept was, is there some way that we can do this without getting the facial every time? And if so, then I think we can improve our results tremendously in being able to operate on smaller tumors. And as our diagnostic methods were improving with better studies of the caloric studies of the labyrinth, we had better hearing testing at that time. We were just beginning to get into panopaque studies. So all this was improving, and the whole key was we had to be able to save the facial. We had a meeting one time with a Leverkrona. We were talking about that earlier.
Yeah. Wonderful.
Maybe you can talk about some of his
Well,
concepts.
Dr. Leverkrona is kind of my hero because he was very encouraging to Bill and myself. Well, Leverkrona in the 60s had done more acoustic tumors than any neurosurgeon in the world. I think he'd done 800 of these. He'd written extensively about it. Well, Leverkrona recognized the anterior-inferior cerebellar artery syndrome. He tried and succeeded occasionally in preservation of the facial nerve. He recognized the danger of prolonged retraction of the brainstem. Bill and I were doing things that Leverkrona dreamed about. And he, I think we had that symposium in 1964. And Leverkrona at that time...
And he was great to come over from Sweden.
He
all the
came
way
over from Sweden.
Yeah.
He was in his 80s at that point in time. He was, but I think at that meeting, we probably had the greatest assembly of neurosurgeons that professed an interest in acoustic tumor surgery. We had Dr. Poole, who had written about this. There was Dr. Mayfield, Dr. Poppin, Dr. Poppin's book. Of all the neurosurgeons that were there, I think really the only one that understood what we were doing was Dr. Leverkrona. He was very helpful and encouraging to Bill and myself. And the only other, I remember Dr. Kernahan was there too. And he was the neuropathologist at the Mayo Clinic. We had him here too. And he was also just amazed that instead of taking the tumor out and not caring about the facial nerve in particular, that we were able to save it. But I don't know, Leverkrona to me was someone that was way ahead of his time, and as I say, he's one of my heroes.
Yeah, just a little more background on that meeting. It was held at St. Vincent's Hospital. At that time, one of the fortunate things that had happened was that I had worked with Jack Urban, a name which anybody who now knows about the microscope and some of the accessories and stuff is a very familiar name, because Jack developed the TV cameras, he developed the viewing tubes, he developed much better lighting for us, and he perfected and would often line the optics in the scope so that we didn't get so much double vision with it and so on. And so Jack had perfected all these things, and so we decided, brashly I think now, I'm looking back at it, that we were going to have this meeting in which we would demonstrate acoustic tumor surgery in our old black and white TV down, and we had it all wired down to the auditorium from the
That was great. I mean, that was like, here it is, this is what we're doing, please. We were kind of pleading for these people the neurosurgical community to try to understand what we were doing and accept it. A lot of the things that Bill is telling you is the antagonism that existed at that time. But go ahead, Bill. I'm sorry for interrupting you. But the meeting, I think, was what we were trying to do was, well, I think we were trying also to develop discussion, frank discussion between the two disciplines about, you know, techniques, and that unfortunately never came out. But go ahead, Bill.
But anyhow, we did have this black and white television. We did 2 tumors on television, and it was the first time that many of these neurosurgeons particularly had ever seen anything through the microscope. And that was, I don't know quite their reaction. The only one that I remember something about was Collie McCarty, who was at that time head of the neurosurgery department at Mayo Clinic. During one of the breaks, sort of got me off to the side, and he said, "Well, now, what about this microsurgery? Do you think I should really get interested in this?" And I remember saying, "Collie, I think it's absolutely essential that you do, because if you don't, I think in 5 to 10 years, you're just going to be out of the mainstream of intracranial surgery." I don't know. I think whether he ever really did get into microsurgery, I don't know. I didn't follow his career that much, but certainly that was the feeling of, well, not only are they showing us these techniques, well, not only are they trying to save the facial, but they're also showing us this microscope. And so it was apparently kind of a meeting where there was so much going on that there was just a lot of controversy, and we didn't really get as much out of it in terms of them trying to help us go from where we were to better things, because they just didn't, in many cases, understand what we were doing.
Well, I think a lot, in that era, a lot of Dr. Poole and Dr. Mayfield and Poppin and Dr. McCarty, these people were outstanding surgeons. But we were doing things better than they were. And we were getting better results. We were saving the facial nerve. We were operating in maybe half the time that they were doing to do the same thing. And I think this was difficult to accept. Plus, I have the feeling that they really didn't understand the anatomy of the temporal bone and what we were trying to do. And there was a lot. And you know, I think in any endeavor in medicine, as I look back on some of the things, I think any time you're a pioneer, you're going to be maligned, as Bill has been. And that's okay. I think that's as it should be, because I think doctors should question what their colleagues are doing. But the thing that would really bother me was that, you know, this would go on and on and on and on, and it was not, it got to be somewhat irrational. And that kind of bothered, and it has even up to now, it has bothered me. I think the discussions, if they were on the basis of what we were doing, which is what Bill and I always tried to encourage, and we didn't get that at first. And I think as a result of that, neurosurgery has lost a lot. I think there's been a lot of reluctance, certainly in the first years that we were working together, to even accept this. And as slowly as more neurosurgeons got into this, learned to use the microscope, learned about the temporal bone, I think this has gotten to be accepted more and more.
Well, I really feel that too, and I think that today, fortunately, we 15 years ago had surgical techniques that exceeded our diagnostic capability. In other words, we could take out small tumors if we could diagnose them. But a lot of times we couldn't we couldn't even find the tumors till they were larger. The introduction of Pantopaque helped a lot in that, in being able to find smaller tumors. And still, so many of the cases that we got at that time were very large tumors because of our diagnostic capability. But as diagnostic procedures have improved, particularly with the scanning, we still, fortunately, have surgical procedures that are capable of management even more effectively, the small tumor, than they were with the very large ones.
You know, I think that brings into focus what I think is one of the problems in the era we're in now. And I think it's a battle that should be fought and discussed, is the what do you do with the small asymptomatic tumor? Do you operate it? Do you watch it? This is, with the MRI and gadolinium, we're picking up pea-sized tumors now. And a paper that Crow and Hardy wrote, I think, was that in the 30s or early 30s?
Yeah,
It was,
in the early 30s.
Yeah, on autopsies at Johns Hopkins in patients dying of unrelated problems. The incidence of angled tumors was 1.5%. That's a lot of tumors. And I think what we've operated on up to this point have been you know, minuscule in terms of the number of these tumors that exist. And I think the problem in the next few years is going to be how do you treat the small asymptomatic tumor? And I don't have an answer for that. Do you have any?
No, I think that will be something that we're going to have to somehow statistically almost approach, because we don't know the growth rates of these tumors. We don't know those that are going to go ahead and really cause more serious problems. We do know that the smaller the tumor, the better shot we have at no facial weakness. And I think it's because we're getting smaller tumors now that
or hearing preservation.
Or hearing preservation.
Exactly.
Because Bill and I were the first to actually publish hearing preservation with removal of tumors. I think that's been lost sight of a great deal, because we've always been interested in preserving hearing, and I think the feeling has been that that's not the case, but that is very much the case. So with the small tumor, we probably have a much better shot at preserving hearing. In fact, when we do find a tumor that we consider small enough to try to preserve hearing, in other words, one that's confined just to the internal auditory canal, with hearing that's better than 50 decibel loss or 50% discrimination, we have about a 50 to 60% chance of preserving useful hearing in that ear. And the chances of getting permanent facial nerve damage are very small. I'd say in the probably, what, 5% maybe.
Oh, yeah.
And so as we get into this whole thing about removing very small tumors, it's going to be a matter of whether or not we will go ahead and take them out in an attempt to save both hearing and facial function. And if we can get to the point where we're able to do that in a much more reliable way, I think these small tumors would be better removed than to allow them to go ahead and destroy and cause more neurologic symptoms before being removed.
You know, I think this is an area where there is legitimate difference of opinion in the traditional neurosurgical approach to the cerebellopontine angle with a conventional suboccipital operation. In my opinion, that operation is not a good operation for a tumor impacted in the internal auditory canal solely. I mean, I'm talking about one that's, you know, there's no extension outside. But I think it's become extent in neurosurgery now to observe these tumors. And I think if you, in my opinion, the reason doctors are doing that is because they don't have a good operation for it. And I think we should, you know, we should discuss this. Drilling off the posterior lip of the internal auditory canal does not allow you access into the lateral end of the canal, plus it subjects the facial nerve and the hearing to destruction. And this is just not the kind of operation that is acceptable to a patient with a small, in many cases, asymptomatic tumor. The procedure that we would use in such a case is a middle fossa approach, which allows direct access to the internal auditory canal. And more, we are seeing this kind of patient as we use the gadolinium studies.
Well, maybe we can kind of wrap it up. We've reminisced for quite a bit, but what do you think about the future, Bill? I was just thinking in terms of, you know, where this is going to go, and of course, it is our firm goal that we can someday remove all of these tumors with no increase in neurologic deficit. Now, we might have some minor increase in deficit if we have to take out the vestibular nerve, where most of these tumors start, but if we can save the hearing, save the facial, then I think, and reliably do this, that the surgery for the very small tumor will ultimately be considered very worthwhile. And I don't know, maybe you have some other thoughts about the future of this, but I feel that the team approach, as we've been talking about, is very vital, that it is a viable way to go, because I think we need to have all the skills of ophthalmology, neurology, neurosurgery, otology, anesthesiology, and so on, brought to bear on this sort of problem, and in that way we get the very best results for our patients. I think that's beginning. We're going to see this now a lot. Most of the young fellows that we train do go out and join up with a team like this, and I think it's much for the benefit of the patient.
Bill, I think to your credit, you have never attempted to do this by yourself, even in the early days when I think you could have gotten away with it. Because at that point in time, your operation was better than what we had in terms of the mortality, a 40% mortality. You brought that down right away. And I think Bill has always presented this as a team approach. And I think that that's been something that I think as neurosurgeons we should not overlook. Whether we like it or not, it was the otolaryngologist who introduced us to the operating microscope. And it's been the otolaryngologists who have been the pioneers in all the approaches to, the basic approaches to skull base surgery.